I'm sure every one of you know me. I'm Dr. Lua, I'm a anesthetist. And before I joined this hospital in 2023, I was a national head for resuscitation at MOH level. National head of advanced cardiac life support, 2013 to 2023. And I have written the Malaysia resuscitation policy 2010, 2015, and 2021. And I also I'm the main person who actually written the Malaysia NCOT. NCOT is National Committee on Resuscitation Training. NCOT Advanced Life Support Training Manual 2010, 2015, and 2021. I'm also writing up the Malaysia Basic Life Support Training Manual 2017 and 2021. Alright, the next guideline will come out actually this year, October 2025. Yeah, correct. So that's the next guideline. Okay, so a little bit introductory about this advanced life support. These are the things that we are going to go through. You got to understand what is the history of resuscitation in this country. You need to know, is there a difference between advanced cardiac life support and advanced life support? What is ILCOR? ILCOR stands for International Liaison Committee on Resuscitation. What is NCOT? National Committee on Resuscitation Training. You need to know what is the effective team dynamic in ALS, and what happened is a difference between resuscitation during the COVID pandemic, and also ALS cost syllabus and assessment. Alright? Right, I would like to ask you, Yong, I know your name. Is there a difference between advanced cardiac life support and advanced life support? Sorry?
I think same.
You think that's the same? Oh, you think that's the same. Alright, Teo, is that the same? Today you come for ACLS or you come for ALS? You come for ALS. So does it mean that ALS has a lower standard than advanced cardiac life support? Don't worry, don't know pass. Don't know. You think it's the same?
Yes, I think it's different.
You think it's a different. So which one has a higher level? Advanced life support or advanced cardiac life support? Okay, can I tell you that advanced life support and advanced cardiac life support are the same? Since 1991, Ministry of Health actually changed the term of advanced cardiac life support to advanced life support. Why? Because 50% of our collapse victims at the A&E are due to the trauma, right? So with that, they want to name it as just the ALS, because with that, the MOH changed their objective. Why are we training you for ALS? It's because we want to make sure to train you as a first-line rescuer to be a competent first-line rescuer. So we want to make sure that if you are saying that I'm ALS trained, you should be able to revert the collapse until ROSC. ROSC is return of spontaneous circulation. Then awaiting for definite help comes in. Means that whoever comes for this course, we are not going to train you as a cardiologist. We are not going to train you as a anesthetist. We want you to be a safe first-line rescuer. Patient VF or asystole, you revert until sinus rhythm. If this is due to the heart problem, wait for cardiologists to come in to do PCI. If this is because of asthma, pneumothorax, and wait after intubated, anesthetist maintain in the patient in ICU and wait for the physician to do sort out things like this. Clear? So because of this, they changed 1991. We changed the term of ACLS to ALS. So it doesn't mean that ACLS has higher standard. Alright? Clear? Okay. Next one. A lot of us, like senior people, we always say that we are AHA trained. You know what is AHA? American Heart Association, right? So a lot of senior people like me, like we are 60s, we say we are trained by AHA. Why? Because American Heart Association introduced the CPR to this country in 1986. Okay? Then after that, only until 2006, Ministry of Health Malaysia, we formed a group called NCOT, National Committee on Resuscitation Training. And NCOT represents all the resuscitation field in Malaysia, right? It can actually got the Advanced Life Support Subcommittee, BLS Subcommittee, PLS is Pediatric Life Support Committee, TLS is Trauma Life Support Committee, and so on, alright? Therefore, you see, I told you that in 2006, I joined the ALS subcommittee, and 2013, I actually lead this ALS subcommittee. Alright? And 2011, we come up, because you see, later we talk about worldwide guideline, but 2011, because 2010 guideline come out, so ALS subcommittee and we come up our first manual, training manual, okay? And 2016 we also come up, 2017 we come up ALS instructor manual, and BLS team come in to come up their training manual, alright? And 2020 we come up interim guideline for resuscitation during COVID-19 pandemic, alright? And what is ILCO? ILCO is International Liaison Committee on Resuscitation, formed in 1992. In fact, AHA, American Heart Association, formed in which year? Make a guess. Do you know? 1960, before I was born. Okay, I'm in 65. Right? And AHA formed by a group of cardiologists. They formed very, very early. But 1992, worldwide international, worldwide country resuscitation council, they think they should sit together and form a group called ILCO. So this ILCO formed in 1992. What's the reason to form a ILCO? They want to make sure that, to standardize the resuscitation, to make sure that whatever people do definitely has a better resuscitation outcome. So what ILCO do is, inside ILCO got many groups. Got American Heart Association, ERC is European Resuscitation Council, you got Australia, New Zealand Resuscitation Council, South Africa Resuscitation Council, Canada, and until 2006, got this group called RCA. What is RCA? Not right coronary artery, yeah? RCA stands for Resuscitation Council of Asia, alright? RCA, and can you imagine so many countries in Asia, ILCO want to accept only one. So whichever country in Asia will join RCA, and RCA is member of ILCO. Next question, no marks on Pang Ling. Do you think Malaysia in RCA? You have to know this type of history before you, because you are in the resuscitation field. So, do you think Malaysia in RCA? Yes, only this year onwards, 2025. And it's because I am the president of, Malaysia, we have this MIRAS, Malaysia Resuscitation Association, okay? MIRAS has 21 members from everybody in Malaysia, including anesthesia group, including the trauma physicians group, including the cardiology group, including the pediatric group, okay? So Malaysia Resuscitation Association called MIRAS, I am the president now, 2025-2026. And we have been applying 9 years to become member of RCA, and this year, we are inside RCA. Good, must keep our hands above. Because once we are in RCA, we can actually get involved directly with the ILCO guideline, things like this. That's why this year, October, I'm going to Rotterdam. The only invited from Malaysia, right? I represent Malaysia, okay? And we are sitting in for consensus meeting for ILCO 2025 guideline. Okay, so the October 25th, the guideline will be released. Alright, okay, so this ILCO, what happened is all the members chip in money to conduct research. So every 5 years, end of 5 years, they will meet up together, we call a consensus meeting, and all the experts, they will discuss, debate, accept or reject the study outcome. Then once they do, for example, 1 year, they actually do a study on whether all the collapse must do cricoid pressure or not. Will you do? In A&E? No, right? Because the outcome of the study say that should not do it routinely. Because if you are not anesthetic trained, you simply press the throat, you actually can cause upper airway obstruction. So it's because of ILCO has conducted this type of research, then outcome is should not do. So actually they come up with treatment recommendation, they call treatment recommendation. Cricoid pressure should not be routinely done for any collapse patient if you are not trained. Alright? So that's how ILCO do. So ILCO will come up something called treatment recommendation, and all these treatment recommendation, like on the day, like for example this year 25th of October, will be released to all the members. So therefore AHA will develop this and come out their own guideline. ERC will develop this and come out own guideline. You know, so the core knowledge is the same. For example, you know, because when you go online, you can see AHA got different way to do things, ERC got different way, right? Simple as that. Bradycardia. Bradycardia, what is the treatment? Is atropine 0.5 milligram every 3 to 5 minutes until 3 milligram, correct or not? ERC guideline 2021 is 0.5 milligram every 3 to 5 minutes up to 3 milligram is 6 doses, correct? AHA guideline is 1 milligram every 3 to 5 minutes up to 3 milligrams, so it's 3 doses. So these are a small difference, but the core knowledge for the treatment recommendation for bradycardia is you should use atropine. And why different people has a different way of doing things? Because they're supposed to do something that they think is suitable to their nation. So what about NCOP guideline? NCOP, you see, to say honestly, NCOP guideline is not lower standard than AHA guideline or ERC guideline. It's just that NCOP represents Malaysia. So this is our Malaysia guideline based on ILCO treatment recommendation. Clear? So Malaysia guideline, when we prepare our NCOP guideline, so we look at all those research paper, and at last NCOP ALS, we decide to follow the ERC guideline because got more paper to suggest it. And you know, all the while we are using 0.5, then suddenly you change to 1, then very confusing. So bradycardia, we also use 0.5. Clear? Alright, then NCOP I mentioned to you already, and now I want to tell you why you need to do ALS. Why do you need to? It's because now we are, I won't say we are greedy, but I tell you, the end point of resuscitation is not only to revert the collapse, it's not only to get return of spontaneous circulation. We also hope that the victim or our patient can have an intact neurological survival, correct? You know, they collapse, they revert, then become vegetative. What is the point, right? And now we are a bit more greedy. 2021 guideline, not only intact neurological survival, they are talking about go back to work, correct or not? So therefore, the chain of survival for 2021 guideline, add another chain is a recovery. Okay, right. And this is how you all need to behave in the resuscitation setting. That either you are a team leader or you are the team member. Of course, in Malaysia, the local setting, we always need a doctor. But doesn't mean that doesn't mean that the doctor knows everything. Sometimes we have a senior instructor, senior people, like for example, ICU Sister Chin. A tongue in the 7B. If patient collapse and a doctor not here, then they will become a team leader. And any one of you can be team leader, right? Depends on that time. So team leader, what you need to do is, number one, you should organize your whole team. You should decide who to take care of what. You know, you definitely have one to take care of airway, one to take care of ventilation, one to take care of the drug things. So you have to identify your group member, alright? And you are the one who gives the instruction. Number two, the team leader have to be very knowledgeable, because you got to know if this patient collapse, what algorithm you are dealing with. Whether this patient collapse because of VF, or this patient collapse because of asystole, or this patient collapse because of unstable SVT, you got to identify, right? Then you got to give your instruction who to do what and what to do. Whether this case require cardioversion, require defibrillation, or just require drug. If require drug, what are the drugs you need to use? The dosage preparation, you got to know. Clear? Alright. Then, if you are a team member, you have to know your part. People tell you to do chest compression, you don't put your hand on the stomach. Right? And people tell you to give the drug or prepare the drug, you need to know. You cannot go, wait, I go and check the dosage and all this. You cannot. Right. So that is the whole team dynamic. Right. A little bit about resuscitation during COVID-19 pandemic. You know, during the, I'm sure you all gone through this time, right? Anybody gone through this period but experienced any resuscitation? Ada tak? Ini tak ada. Patient COVID semua lari. But you're lucky because in GH, we have a lot of this type of patient come to A&E collapse. Of course, during, I just want to remind you all, for resuscitation, general principle. What is the first principle for resuscitation? Who can tell me? What is the first principle of resuscitation? Yes. You understand what is the first principle of resuscitation? Number one is take care of yourself. Correct. If you are not safe, how are you going to save your people, your victim? So the first principle is take care of yourself, especially during the infection, pandemic, this and that. You must make sure you are well covered. Means that minimally you must have an N95 mask. I always keep an N95 mask in my bag, in case that anybody collapse, you put on your N95 mask. You know why? Because CPR, intubation, these are all we call AGP. What is AGP? Aerosol generating procedure, okay? So dangerous. You want to scope people, then everything will fly to you. Correct or not? And you will get it. So always must have an N95 in your bag anywhere, correct? Of course, we don't talk about PAPR, that type of astronaut. Forget about it. You won't have that, and you don't have time to it. But you just need to remember the first principle of resuscitation is take care of yourself. All right? And what's the second principle of resuscitation? Second thing is do not cause harm. Alright? You don't do something can further kill the patient. So means that that's the reason why today you need to come for the ACLS course, right? You need to learn the right thing. You need to know what are the right things you need to do before you can save the patient. Remember this, First principle is to take care of yourself. Second principle is do not cause harm. Alright, so during COVID-19 pandemic, we always remind our junior people, you must be careful. So during COVID that time, we have to minimize the people for resuscitation. We don't make sure the husband to go and intubate because they cannot. We have to keep the most experienced people for intubation because we want one shot in. We don't want to try 10 times and everybody get it. Okay, so during the resuscitation for the COVID-19 pandemic is as minimal as possible people in the resuscitation scene. Number two is the most experienced people to be there. So that time most of us are actually doing the front work rather than our junior people. Alright, so that's important. So is there a difference for COVID-19 pandemic? It's the same. The resuscitation is the same. Alright, you just need to make sure you have something to protect yourself because it's an AGP, aerosol generating procedure. And we have to make sure you weigh between the safety, resuscitation and everybody's safety, alright? So, is there an emergency during pandemic? Actually, to say honestly, I have to tell honestly, even we are lucky because most of our senior will tell us that get ready everything before you jump into the patient. Alright? And no emergency in pandemic, stay safe and do not cause harm. These are of course, these are all the PPE that you got to prepare, but I tell you, minimally, you must have an N95 mask. If you have a goggle, you have a face shield, you do that. Then all the glove, head cover, whatever. This is if you can have time to do. If not, minimally an N95 mask and your glove. Okay. Alright. That is the most important. Just now all these things exam won't come up. But you need to understand, especially you are here and you are in the resuscitation field. Advanced life support, what are the syllabus? Like I said, mentioned earlier. One is you got to go through the lecture. Because this book is given to you sometimes, right? I'm sure, I trust you, I'm sure you have flipped through. But how much can retain inside Susan? Not easy, right? And that's the reason you need to come for the lecture. Because I will highlight the important things to you, alright? So you have a core lecture, you will also have a skill teaching. What is skill teaching? Mainly the airway management, okay? All the gadgets that you're supposed to know. then you also will be taught how to handle the defeat machine. You must understand, because you see there are many types of defeat machine in the market. Okay, A&E use what type of defeat machine? Military. Okay, got no IC people. What is in? Do you have a defeat machine here? What brand is that? Also, we come into the market. IOD. Okay, ask you the next question. What are the energy joule on the Minray machine? What is the lowest energy joule and what is the highest energy joule? Any of you have noticed? Later you go back, you go back to your working area, have a look. What is the highest energy joule and what is the lowest energy joule? This is important because now for the defibrillation protocol, we can do an escalating energy protocol. Means that whatever you can increase the energy joule as long as the machine got this one. Answer the question. Okay. So another thing is the exam, alright? So for skill station, we also go through the ECG with you. We also go through electrical therapy with you, airway management, and also megacode. Remember, ECG in ALS is different from ECG caused by cardiology. ECG in ALS, we only need you to identify the rhythm. Means that the ECG prop come out, oh, this is VF. ECG prop come out, oh, this is SPT. We are not teaching you about small print like QRS complex, ST depression, what is the delta wave, what is J wave, what is the... No need, okay? You know, no need. So the ECG for ALS is, once the ECG come out, then you immediately know that what is the next step. You are dealing with what type of algorithm. So later ECG session, you have to concentrate on that. Don't worry about ST depression, how many boxes. Normally we don't test you on that. We only test you on the rhythm recognition. Clear? Okay, then how about exam? That's the most important thing. Exam got two parts. We have a theory exam and we have a practical exam. In order to pass the ALS and say that I got a certificate of competency, and it means that I'm an ALS certified, you must pass both. You must pass theory plus practical. Theory got two parts. Theory, we give you an MCQ, like just now you've gone through the pre-test, and we give 40 questions. And ECG got 20 questions. MCQ is choose the best answer. ECG is, we give you a 20 ECG, 20 answer, match 1 to 1. But if you don't know one, sure you got 2 wrong. Correct or not? Something like this. What is the passing mark for theory? What's the passing mark, do you know? What you expect? Oh, 80, I'm not so cruel. You say 80. 85? No. 35? Oh, no. MOH, this is based on Ministry of Health. MOH requirement is 75%. Okay, so 40 questions, the most you can get it wrong is 10. You must have at least 30 and above, 30 over 40. That is MCQ. ECG 20, you must actually have at least 15 over 20. Clear? So you pass the 2 theory, then only you are invited for practical. So today you pass, then we will text you, please come for practical tomorrow, means that you pass the theory. Oh, okay. If theory failed badly, I'm so sorry. No, it's like, because if you know your theory not strong, you don't have practical, you cannot read the ECG. How are you going to do your management, right or not? Okay, practical. Practical also got 2. One is the airway practical and one is the megacode practical. Airway, later in the airway station, they will give you a syllabus, a list, 1 to 10. So all the things listed there you got to do. including basic like airway oxygen delivery devices, including some specific maneuver, open airway maneuver, jaw thrust, then okay, the most important thing is LMA insertion and intubation. These two are the must. LMA is number one important for all the paramedic. 3 attempts, tak boleh masuk, tak boleh pass. And intubation, 3 attempts, tak boleh intubate pun tak boleh pass. Clear? Okay. Then mega code. Mega code is we give you a case scenario, we give you a full-length mannequin. In fact, this mannequin can talk, but I don't let him talk. It's confusing. So we give you a full-length mannequin, and we give you a case scenario. You may get a case that patient already collapsed, already mati, alright? But then, very easy. If patient is already collapsed and you have to do CPR, you're only dealing with 4 algorithms, VF, pulses VT, PEA, or asystole, right? If we give, then we also can give a case scenario that the patient can talk. Doctor, I cannot breathe, something. But if this type of patient can talk, you only 2 algorithms you're dealing with. Why? It's either the heart beating very fast or the heart beating very slow. So simple as that. Don't panic. So, ALS, the most excellent mannequin, right? So you've gone through once, when you really come across the case, then you will have you have some idea. I'm sure you will do better. Correct or not? So mega code, airway to say is all and none phenomenon. You know or you don't know. Correct or not? Mega code, how to pass, how to fail. Put it easier, how to fail mega code. If by end of the day you kill my mannequin, correct? End of the day that you cannot revert, then sometimes the examiner will say, now the patient turning a bit bluish color. That one thing. But actually, just to tell you the standard case of failure. For example, in Megacode, I give you a case of bradycardia. 2nd degree type 2 heart block, okay? Heart rate 30. What should you do? Atropine first, right? Then call for pacing if let's say 2nd degree type 2, right, or 3rd degree, right? So, but sometimes when you're very, very panicked, whatever comes, that's why I tell you, the book or the algorithm you must memorize rigidly. Why? Because if you don't memorize rigidly, when you're so stressed, adrenaline surge, and adrenaline cause profound vasoconstriction. So everything constricted, blunted. Top block, so when top block, whatever come up from your mouth will be spinal reflex, right? So sometimes when you're so panicked, instead of talking about atropine, you suddenly say, I want to give amiodarone. Straight failed scenario. Why? Because amiodarone causes severe bradycardia. And heart rate already 30, you go and give amiodarone straight, bye-bye. So that is a straight fail scenario. Of course, we are not so cruel. We will tell you that we will asystole for you. See whether you can revert or not. So another similar scenario is like, I give her a case of supraventricular tachycardia, SVT. Heart rate 180. What should you give SVT? Adenosine. But you are so stressed, especially if I'm your examiner like this stressed. Then you remember it's A. Then you say adrenaline. You know what I do? I will click a VF for you. Why? Because 180 heart rate, you go and give adrenaline 1 milligram is straight VF. Right? Because adrenaline is very arrhythmogenic. You never give adrenaline 1 milligram to a patient with a cardiac output even though it's hypertension. Understand? So you see, these are all how examiner can consider to fail you. Understand? So these are of course tomorrow we will go through a practical and also right. And how we assess you, I can mention already. Theory, MCQ, ECG, skill station is airway, defib, Megacode. So we will do it. And this is a assessment criteria. Passing mark is 75%. Airway station is all and none, and we give a case scenario, depends on how you revert. But we normally will, sometimes you like to walk and drop into a deep drain. We will pull you back. we will say, you know, sometimes, are you sure you want to do that? We are not testing you. When the examiner tell you that, are you sure? You never go and say, yes, very sure. Then mati terus. We are not challenging you. No, we sometimes, I understand that everybody's stressed. Huh? Are you sure you want to do this? Will you want to consider other drugs? Things like this. Okay, yeah? Don't worry, we are not very cruel. Yeah. Okay, so day one is pre-test, you're done already, right? And we give you lecture theory exam. You pass tomorrow, you will be invited for the practical station in the morning and exam in the afternoon. Yeah? Okay, the certification of this ALS is valid for 3 years. This again is Ministry of Health criteria. Okay? Why you put it 3 years? In fact, American Heart Association is only 2 years. ERC is only 2 years. By that time, we think 2 years too short, that we don't have enough manpower to recertify people. All right, so we put it 3 years. And even got people say, hey, why not if 5 years? Because guideline come up 5 years. 5 years too long. Okay, like for example, now you come for it. End of the year, guideline come up, but your certificate valid until 2020. If let's say 5 years, 25, you know, 2029, you know, so too long. So we want you to upgrade yourself with a new guideline. All right. Whether you can receipt or not. Whether you can receipt or not. If you fail the, for example, I told you right, your exam theory is 30 over 40, correct or not? You get 29, or you get 28 over 40. We will give you a chance to receipt. Theory, okay? If your ECG is like 14 or 13 over 20, we will also consider to let you receive. Okay? Then see whether the receipt is always like tomorrow early morning, 7 o'clock. Practical also the same. If you start, we will. If let's say you pass theory already, then you come for a practical. You fail, we can send you to other station to receive the practical. Okay? So we are trying to help you. Clear or not clear? Thank you. Our next lecture is airway management. Airway management is very important in resuscitation because you see, in hospital cardiac arrest, patients don't a lot of them, they don't just suddenly collapse without any prodromal sign. Correct? You know, this type of sudden cardiac arrest is those out of hospital cardiac arrest. When they're jogging halfway, they can sing karaoke halfway, then suddenly they pop and die. Right? But any collapse in hospital setting is definitely has some prodromal symptoms. So therefore, healthcare worker is very important because the patient will give you some signal, I am going to collapse. But if you don't see, then bye-bye. Correct or not? So now we are talking about airway management. Before we start this lecture, I'm sure all of y'all come across pulse oximeter, right or not? Good. I have to ask OT people. OT people all dealing with. Okay. I forgot your name, correct. What is the normal saturation, SpO2? I'm talking about normal. What's the normal SpO2? 9. No. Give me one figure or two. 95 to 100, very big range. Ini kiasu. What's the normal SpO2? If like, I'm sure you are normal. Clip a pulse oximeter on your finger. What is your normal reading? 100. Okay. So my question is, what is normal SpO2? Normal is 100. No, not everybody 100. What do you mean? More than 95. More than 95. More than 95. ANE? Everybody like 95. Is it because I think all of your doctor or consultant will say that, inform me if let's say less than 95. But I tell you, normal SpO2 is not 95. 95 is already too low. Correct? If all of you all, are you a smoker? I have to ask first, who knows that smoking, then they become 92 only. When you click pulse oximeter on yourself, it's always 97 and above. Correct or not? 95 is not normal, 95 is not good actually. But why people, especially doctor, on-call doctor, will tell you, if let's say lower than 95, call me. It's because, of course this is a little bit too advanced for you, but I just want to say that you have to understand there's something called oxyhemoglobin dissociation curve. It's a sigmoid, like this, sigmoid, yeah? Something like this. Okay, so this part is 95%, alright? Oxyhemoglobin dissociation curve is like, you know, the oxygen, because oxygen carried by hemoglobin, right? No? So when the patient needs, then the hemoglobin will reach there and release the oxygen to the cell and all this. So this oxyhemoglobin dissociation curve is a sigmoid, and the minute it drops drastically is at the 95%. So practically people tell you that inform me when it's 95 is because below that will be very sharp drop. So the time to react is very minimal, you know. So you let it drop below 95, the patient will drop very fast, the saturation. So you don't have much time to move. So 95 is so-called a crucial cutoff point. But normal SpO2 is not 95. It should be 97 and above. Okay, so you don't take everybody 95 happily that say, oh, it's still normal, right? It's because the minute drop below 95, the patient will be in trouble. But that's not talking about people very old age or people with COPD. Because PaO2, we haven't started our lecture, because you know, if you take the patient ABG, okay? We say patient blue or patient hypoxemic, what you expect the PaO2 to be? You understand my question? If let's say we say somebody tak cukup oxygen already blue, and in a medical term is hypoxemia, so you take an ABG, what will be the PaO2 be? Less than what? Sorry? Less than what? Yes, less than 60 millimeter mercury. Your PaO2 less than 60 millimeter mercury is hypoxemic. But we are not going to pick everybody ABG, right? It's not possible, right? So therefore, my next question is, if you click a pulse oximeter on the patient, I told you that 97% onwards is normal, 95 will be crucial, but when you say this patient is hypoxemic, PaO2 less than 60 millimeter mercury, what will be the saturation tell you? You understand my question? I'm asking you, if let's say you know this patient is blue, means that PaO2 of 60 millimeter mercury is equivalent to saturation of berapa percent? Siapa kakak lab? Kalau orang kakak lab akan ini. Yes. Adil, my GNS. Make a guess. 90%. 90% in saturation is equivalent to 60 millimeter mercury in the blood. But why people don't tell you at 90 only call me is because oxyhemoglobin dissociation curve drop very drastically after 95. So practically people tell you that to inform me if less than 95. But the really blue is 90% equivalent to 60 millimeter mercury. Clear or not clear? Alright, so now only we want to start our lecture. Because if not, you know, the saturation of how many percent, you got no idea. How low is low, you also got no idea. Right. Another thing, before we talk about this, sometimes you will inform doctor about ABG, right or not? Whether it's OT, whether it's a ward. So, for example, I want to inform you in ABG lah. So I'm sure you are the nurse, you come across ABG, correct or not? Psychiatric or mungkin tak ada. But no choice, you know, A&E selalu, right? So if pH, you know, it will tell you that this pH what is a normal pH? 7.35 to 7.45, right? So I give you a normal 7.38. What is a normal PaCO2? 35 to 45. So I also give you normal, 40. This is PaO2, I give you 220 millimeter mercury. High or low, good or not good? High. High good or not? Not good. Why high not good? I heard people say oxygen toxicity. Whatever it is, you think it's not good, correct? What is the normal bicarb? 22, so we give you 24 lah, normal lah. Normal base excess -4, SPO2 100%. Okay. If I call you about this case, this ABG, 3 a.m. in the morning, but a lot of people will scold, oh, you call me at 3 a.m., right? What will you do? For example, if this patient is oxygen high flow mask, 10 liter, non-rebreathing type, means I got 3 valve, no air mix. So if I give you this ABG with the patient on oxygen high flow mask, 10 liter, non-rebreathing type, what will you do? What will you do? You are in the ward, your patient on this one. Then 3 o'clock you call Dr. Sundira, so kena marah. Then what will you do? Then you dare not to call, then you do sendiri. Change to rebreather. What will you do? Patient on high flow mask, you nak tukar nasoprom ke? Lower oxygen level. How to lower oxygen level? 10 liter. Or you want to change your face mask, simple face mask, 6 liter? Better. Right, what about you? Change your face mask. Pangling? Change to non-rebreather. Change to rebreather, 10 liter. What about you? Simple face mask. But all of you, do you all agree that this PaO2 of 220 is not good? Too high oxygen, must cut down oxygen. Do you agree? You agree. Who doesn't agree? More reason you should need to come for ACLF. Okay, this is I give you a case scenario. It's a real case. When I was in GH, okay, we got a patient in CCU, massive MI, intubated on 100% oxygen. But too sad because in the CCU there's no anesthesia in, so patient wrestles, pull out the tube, self-extubated, okay. Then they put patient on exactly is this one, high flow mask, non-rebreathing type, 10 liter, okay. Took the ABG, this ABG, okay, and they give the result to a houseman. Like you all, houseman, wow, too much oxygen, not good. So he ordered change to a nasoprom oxygen, 4 liter. Within 5 minutes, the saturation from 100 dropped to 65, and patient dropped dead, died before we rush to intubate the patient. Why? It's because you cannot only look at the PaO2 by itself. Have you come across, if let's say you are normal, okay, I give you, do a study on yourself. You put on yourself on high flow mask, non-rebreather, 10 liter. High flow mask, non-rebreathing type 10 liter is near 100% oxygen to give to your patient. After 20 minutes, take your own ABG. What will be your ABG like? If you have no lung problem, if you are not a smoker, and this ABG can be 500 millimeter mercury, do you know? So, and you need to understand, FiO2 is how much inspired oxygen give to you, and PaO2 there's some correlation. Of course, the detail have to go through alveolar air equation, forget about it, you don't need to know. But generally, you must have the knowledge. FiO2 and PaO2, the conversion rate is times 4 to 5. If you give 100% oxygen to your patient, you take an ABG, your patient got no lung problem, the patient can reach 500 millimeter mercury. This is the one that you need to understand. So therefore, this is a real case. I like to teach this type of case because the patient died. And it because of no knowledge for the husband. So this patient, 220, he got a lot of discrepancy. You know, by right he should have 500 something PaO2. He only have 220, means that he really need oxygen. So you cannot simply remove his oxygen, become a nasal probe, because nasal probe, 1 liter is 24%, every 1 liter on top of that you add 4%, 2 liter is 28%, 3 liter is 32%, 4 liter is 36%. So immediately from high flow mask near 100% oxygen, you drop to a nasal probe, immediately, that's why his saturation dropped to 65 within 5 minutes. And his massive MI, so he died. So, when people give you the ABG like this, you actually have to ask few things. I already provide you the story, the detail that this patient on high flow mask non-rebreathing time means I give near 100% oxygen to the patient. A patient only have 220 is not too much oxygen. Nothing about oxygen toxicity. He is not enough oxygen and he needs oxygen. So you cannot degrade, de-escalate the oxygen supply. You understand? Right, so be careful, and don't simply, oh, so much oxygen, I have to cut down. No, I've seen 550 millimeter oxygen. Okay, it's because lung got no. Like for example, you give 40% oxygen to your patient, and your patient's ABG come back is about 180 to 200, means that your patient don't need oxygen. Correct? If 40% times 4 is 160, times 5 is 200. If this patient got 180 millimeter mercury, patient don't need oxygen, buang, nasal probe. Clear? So that's important. Then why subsequently we are going to teach you airway management, oxygen hierarchy that you got to know, nasal probe, face mask, high flow mask, how many liter oxygen we give, because we want to know roughly how many percent oxygen we give to your patient, and because we want to interpret your ABG. Clear? Okay, now we talk about oxygen delivering devices. First one is a nasal probe, like I say, in the air is 21%, first liter is 24%, every 1 liter on top of that is at 4%. Alright? Good thing about nasal probe is very simple, comfortable, patient can talk, patient can sing, and most importantly, very safe. Why? Because if you finish the oxygen from the cylinder, patient won't die because can breathe oxygen from the air. Right? Second thing is simple face mask. This is Hudson mask or simple face mask. 6 to 10 liter, you can give 35-40% oxygen to the patient. This one is Venturi mask. Okay, this Venturi mask used for which type of patient? Why? Yes, it used for COPD patient, chronic obstructive pulmonary disease or airway disease. Why? What is the keyword? Why we want to use the Venturi mask? The most important thing is you can give desired oxygen concentration of oxygen to the patient. Means that you don't want to give unnecessary high oxygen to the patient. Why COPD patient need this type of mask? What is the keyword? Keyword is COPD patient require something called hypoxic drive. What do you mean by hypoxic drive? Because you give them too much oxygen, they don't breathe well. It's because everybody's brain, your brain, my brain, semua sama. We have a center called respiratory center. Alright? And our respiratory center is sensitive to low oxygen or high CO2. Whenever got these two triggering factor, then the respiratory center of our brain will tell us, breathe faster, exhale faster. Because in high CO2, you exhale faster, CO2 will come down. Low oxygen, you inhale faster, oxygen will come in. Correct or not? So everybody's brain sensitive to these two. But to say honestly, more sensitive to high CO2. Okay. But what happened to COPD patient? They are chronic obstructive airway disease. So if you take the ABG from their blood, definitely CO2 very high, can be 50. Alright? So respiratory center of this type of patient, sudah lali, already immune to high CO2. So what left in the respiratory center, the factor to ask them to breathe better is low oxygen. But if you unnecessarily give them high oxygen, they got no stimulant. They don't breathe well. You understand what I mean? So therefore, in a COPD patient, you give this type of thing, then you can, the principle is the venturi mask over here. That is a window that you can on or off to increase or reduce the window opening. All right. So you want to more air to dilute the oxygen, you turn the window open, then more air to dilute the oxygen. So you can cut down the concentration. Because whatever come out from your flow meter, all this is actually 100%. So you put this type of mask, then you can control. You want more dilution, you buka tingkat besar sikit. You don't want dilution, you tutup the tingkat, something like this. Alright? So venturi mask, they use a Bernoulli Venturi's principle that you actually can give desired oxygen concentration to the patient. But I want to tell you another case. These are all real cases. When I was at MO, then we actually call for resuscitation, mainly intubation. There's a COPD patient in the ward that saturation 70. You know, saturation 70, PO2 probably 40 only, correct or not? That patient is so blue, like this kind of color. Then patient, okay, the patient is on nasal oxygen only, because their thinking is the COPD, you cannot give oxygen, correct or not? That is the thing. But if your patient is so blue and they don't breathe well, and the next step you need to intubate, you give 100%, right or not? So while awaiting for, you want to prepare for intubation, especially in the ward, not like OT or ICU, or A&E is well prepared. You take time to prepare, right? So no choice, if not, I don't want the patient to collapse before I intubate, right? So I said, put the patient on high flow mask, because at least you give them more oxygen, they can tahan a bit, right or not? So I was scolded badly by physician. What nonsense you are talking about? My patient got COPD. That is a very wrong thinking, correct? Because if your patient needs hypoxic drive, but your patient is so hypoxic and cannot drive, you drive for them, right or not? So these are all general principle. Another case that I want to share with you all is also, I was also called to resuscitate a patient in the ward that happened in UH. So I rushed there, the patient's CPR, and I saw the kidney dish already got 50 broken ampule of adrenaline. And this patient got a granular there, no line. Correct or not correct? Because their argument is, this patient collapsed because of APO. I was also scolded by physician. They say acute pulmonary edema, acute heart failure, so cannot give fluid. But this is another wrong conduct. Because if patient collapse, there is no circulation, no cardiac output. Whatever you give your 50, 100 ampule adrenaline, all here. Remember, our CPR can only generate, the best is also less than 10% of cardiac output. Do you think the adrenaline can go to the heart? Cannot. So this is principle, you have to understand. No, whatever reason your patient collapse, as long as you are doing CPR, you give the drug, you must have a running drip. And in the textbook, or I tell you, tomorrow exam, in the ERC textbook, they actually got a standard protocol for you to say during the resuscitation. Rapid bolus adrenaline 1 milligram followed by saline and elevate the hand. I expect you all to say this because this is practical. So remember, even though the COPD cannot give too much oxygen, at the end point you no choice to give them oxygen, right? Even though it's heart failure, when they collapse, you still have to have a running drip before when you give the drug. Clear? Hey, a lot of wrong things conduct. Alright, so next thing is actually high flow mask. Like I mentioned earlier, high flow mask got two types. High flow mask is non-rebreathing type, means that got 3 valves in between. Later we will show you in the airway station. Then a high flow mask with non-rebreathing type. Okay. So if you have money to buy, I like to ask this question in the exam airway station. I said, if you have money to buy only one, which type you want to buy? You want to buy with the non-rebreathing type, or you want to buy with rebreathing type? Yes, because rebreathing type, you run 10 liters, already can achieve near 100% oxygen to your patient. But if you use a rebreathing type, you run 10, 15 liters, can only achieve 80%. Correct or not? Right. Okay, next one. Open airway maneuver, we expect you to show us in exam. It's because tongue pop backwards. So you can do head tilt chin lift, or you can do jaw thrust. This is jaw thrust. This is indicated for those with suspected cervical injury. Jaw thrust. You have to perform these two maneuvers. Next one is oropharyngeal airway and nasopharyngeal airway. Measurement is important. We will show you how to do this. Is oropharyngeal airway, of course, from the oral cavity to the pharynx, right? Measurement got two types. One is the angle of the mouth to the angle of the jaw, which is earlobe. Alright? Angle of the mouth to angle of jaw. The other measurement is from the mid incisor to angle of mandible. Mandible kat bawah, jaw sini, bawah is mandible. So there are two measurements that you have to show us. Alright? Then, nasopharyngeal airway is from the tip of the nose to the triggers. Alright? Tip of the nose to the triggers, tengah-tengah telinga. Alright? And generally, nasopharyngeal airway is easier to be tolerable because it's softer and smaller. So, if your patient got a gag reflex, I think you cannot open mouth. You open mouth, it bite you. No, because you see, GCS of 10, 11, they have a gag reflex. So, but they call it a bit obstructed, then you can put in nasopharyngeal airway. But nasopharyngeal airway, the only contraindication is if you suspect base of skull fracture or any ENT bleeding, then you don't do it. Alright? Okay, this one I show only in the exam, we don't ask you. There's something called pocket mask. Last time I used to keep one in my pocket. Why is it called pocket mask? Because you can fold and put in your pocket. And good thing about pocket mask is because it has a one-way valve here. So you blow to the patient, whatever patient's infection debris won't come back to you. Okay? And this is important. This is back valve mask. Don't call it embu back. Embu is a brand. Back valve mask. Back BVM. Okay. Most importantly, you need to understand back valve mask because it contains one-way valve here. So you can never allow spontaneous breathing by using back valve mask. Never. Remember, because you don't squeeze the back, the fish mouth valve won't open. Oxygen won't go to the patient because oxygen comes from here, the inlet here. Then you squeeze the back, oxygen zoom go to the patient. You don't squeeze the back, oxygen cannot come to the patient. So back valve mask is a gadget or airway device that you can never allow spontaneous breathing. Even in ICU, you want to intubate patient, or in A&E, you want to intubate. When you haven't given drug, you put a back valve mask, you got to follow, slowly squeeze and get oxygen to your patient. Alright? And this is another way you got to show us the mask ventilation. EC clamp technique, one way, one hand or two hands. Okay, this is to make sure that there's complete seal of the mask on the face. Okay, what is correct size mask? What is an adequate mask? Adequate mask on the patient, it has to cover the nasal bridge of the nose until two angle of the mouth. The angle of the mouth tak boleh terkeluar, you lick. So you cover the bridge of the nose until angle of the mouth. This one important. This is called LMA. I can tell honestly, in exam, everybody very stressed. I got participants told me this is LMS. Mulut punya ubat. LMA, laryngeal mask airway. Laryngeal mask airway is a supraglottic airway. Means that this mask, when you go in, it actually sits in front of the vocal cord. When you intubate, the tube go into the vocal cord and you cuff it, right? So therefore, when it's a supraglottic airway, the only problem about this mask is it can never prevent aspiration. Clear? It's not that it causes aspiration now, but it can never prevent aspiration. And you know that it's actually a black line. You look at this, the cylindrical tube, there is a black line. There is a black line here. What is this black line for? Ada kan? Ada garis hitam tu. What is the black line for? Don't tell me it's radio opaque. Now you can see your eye can see tak payah radio. I know people will tell me. This black, you see LMA is a supraglottic airway. It consists of cylindrical tube, elliptical cup, and inflatable pilot balloon. Betul tak? When you chuck the mask into the patient's mouth, what left outside is only the cylindrical tube, right? So this black line is an indicator for correct placement. Once you put in, the black line must face patient tip of the nose. Then only the mask go facing the vocal cord, then oxygen can go. Because you can put it terbalik, then you think the mask oxygen diffuse from the base of the skull to the brain, it doesn't happen, right? So the black line is an indicator for correct placement. It has to face the patient's tip of the nose, alright? And laryngeal mask, this is another. Okay, this is a second generation of laryngeal mask. Remember I told you laryngeal mask cannot prevent aspiration, right? Because it's a type of supraglottic airway. So in order to cut down risk of aspiration, the manufacturer actually come up a new LMA. You notice there is an extra pot here. There's an extra pot here. And this extra pot is for you to put in rouse tube. So when you put the rouse tube will go in from this spot until the end come to the stomach. Because LMA sit in front of vocal cord, belakang is already stomach, right? So you put in the rouse tube, it can cut down the risk of aspiration. It still cannot prevent aspiration, but it cut down the risk of aspiration. But in the resuscitation, you know, LMA is a must in all the resusc trolleys. Because if you cannot intubate, you can tuck in LMA. Because LMA is very user-friendly, easy to learn, very promising ventilation. Alright? So we put LMA. So in the resuscitation, we only teach you the first generation LMA. We know, because this one a bit of technique to put in. Alright? And LMA come in various sizes. You have size 1, 1.5, 2, 2.5, 3, 4, 5. Alright? And it's based on the body weight. So in adult, normally we use size 3 onwards. Because size 3 is 30 to 50 kilo. Size 4 is 50 to 70 kilo. Size 5 is more than 70 kilo. Alright? So it depends on the patient's body weight. And LMA, again, you know, those in OD, you understand, right? I rarely use LMA. It's because our LMA is the one that cannot prevent aspiration. So medico-legally, if patient aspirated, it's our fault. Understand this? Okay. And you know, when you put in LMA, it's supposed to really sit like this. Then you cup. Okay. How much you got to cup your LMA? It depends. There is a formula. Okay. Size minus 1 times 10. If you use size 3, 3 minus 1 is 2. 2 times 10 is 20. So it's 20 ml of the air. You use size 4. 4 minus 1 is 3. 3 times 10 is actually 30. Understand? Alright. Of course, any procedure you do should carry certain risk. LMA, because it's a cup, is big inside here, so sometimes it also can cause sore throat. But it rarely causes dysphagia. Mainly the sore throat and vocal cord. It can actually sit wrongly, so it compress on the vocal cord. The most commonly is a sore throat. Okay, now we talk about endotracheal intubation. Again, endotracheal intubation is a gold standard, especially current situation when you have actually COVID this and that. Last time, you read this statement, intubation during CPR should not exceed 5 seconds. This is very crucial. It's only anesthetist can do. Can you imagine 5 seconds? Sometimes you will scope in also. But why this is a standard statement in the ALS textbook, BRC. Why they actually insist of intubation during CPR is because nowadays, during CPR, we try to minimize the interruption, right or not? Because they say chest compression, you should not interrupt the chest compression for more than 5 seconds. Because chest compression is the most important merit for the ROSC. So, because hand-off chest time cannot be more than 5 seconds, therefore, they actually put it that intubation during CPR should not be more than 5 seconds. Okay, for OT, for any a live patient, I won't say a live patient, elective intubation, normally intubation the time is about 30 seconds. But how do you know it's 30 seconds? Not the clock tap. So I always tell my people, my junior, my MO, the minute you remove the oxygen from the patient, you hold your own breath. If you cannot hold your breath, it means that the patient will suffer, right? So therefore, the intubation for a live patient is 30 seconds, but if you hold your own breath, the minute you cannot take out and back the patient again. Clear? Okay, yeah? Right. So, and intubation, of course, got a lot of complications, you know, because it's very disastrous, and I tell you, last time I got a case, to share, I got an orthopedic surgeon, GH. You know, that time we are so busy in ICU because patient collapsed, and they call for intubation, and worse still, this patient on skull tone. You know, cervical problem. So the patient on the skull traction. Patient on skull traction is definitely comac 3 and above because they cannot extend so then we are so busy, cannot go because it's young, asthmatic, suddenly near collapse, you know. Tension pneumothorax, so we are all busy in ICU. So we cannot go. I said, I cannot help you, do whatever you can. Then after we settle like the 15 minutes, then lari pergi orthopedic ward. Then I said, oh, very impressive, so that intubated, you know. Oh, very good, intubated. Then, but I just said, I never trained him for intubation, he's so pandai. So I asked him, how many times you attempt? You know what he said? Then he started counting his finger. I nearly fainted 9 times. Habis, betul. You see, so, but no choice. That's why I say sometimes, to say honestly, we try our best, you know. But there's also some principle, you know. It's not the time to die, whatever you do, you won't die. It's time to die, whatever you say. But we try our best because there are a lot of unnecessary or premature collapse. If we can, we will revert. Correct or not? So there's good cooperation. So absolute indication for intubation, few of this. Number one, cardiopulmonary arrest. You know, this is provided you cannot adequate mass ventilation. Number two, respiratory failure, whatever reason, whether this due to pneumonia, ARDS, whatever, you also have to intubate them. Number three, talking about airway protection. Which type of patient need airway protection? Which type of patient need airway protection? For example, GCS less than 8, so they cannot protect airway. Or they have a stroke, bowel palsy, they cannot protect airway. But which type of patient? GCS 15/15, but you got to electively intubate them. Not because they go for surgery. You know, I said, which type of patient? GCS full, because just now I said GCS less than 8 to intubate, right? But which type of patient? GCS full, but you got no choice to intubate them. Do you know what? Medical. The patient got myasthenia gravis, correct? Guillain-Barré syndrome, when you know they got the palsy here or the weakness, even though GCS full, but they will aspirate, so you got no choice to intubate them. Okay, so that's under airway protection. Next thing is cerebral protection. Which type of patient needs cerebral protection? Of course, this is a patient with high ICP. But can you imagine, intubation can be very ganas, correct? Intubation can be very disastrous. I always say, you know, no, the patient got fracture, skull, this and that. You look, 3 kali kan the brain should come out from the other side. Right? But why, scary, right? But why do you need to intubate patient with high ICP? And what do you mean by cerebral protection? You want to protect the brain. But how to protect the brain? By doing disastrous intubation. Understand my question? So you tell me, what do you understand about cerebral protection? Protect what?
Cerebral perfusion.
Huh?
Cerebral perfusion.
Haven't come to the proper answer. You see, a patient with high ICP, they definitely, you know, whether it's diffuse axonal injury or intracranial bleed, whatever, it's head injury, right? So they definitely affect their own respiratory center. Remember I told you, everybody's brain got respiratory center, no need to know where exactly got, okay. So in a head injury patient with a high ICP, the respiratory center will be affected. It will be affected either way, we don't know. It affected like cerebral, they affected like depressed, so CO2, they breathe very slow. You know, they hypoventilate. If they hypoventilate, CO2 will be very high, right? CO2 high will cause cerebral vasodilatation. ICP will shut down, right? Then, if the cerebral, the respiratory center of this head injury patient affected in the sense that They hyperventilate. So when they hyperventilate, CO2 very low, right? So CO2 low also will cause cerebral vasoconstriction. Once they constrict, ischemia infarcted, also high ICP, right? So cerebral protection in high ICP patient is because we intubate, control ventilate, control CO2, nothing to do with O2. Because we want to control ventilate, then we can keep PaCO2 35 to 45 millimeter mercury. A lot of time we keep about 30 to 40. Alright? So cerebral protection is because we want to protect their brain from the secondary insult from CO2 haywire. Clear? Yeah. Next thing is critically ill patient. Why patient critically ill, for example, in ICU on 4-5 inotrope, you need to intubate them? It's because when they are BP so low, breathing also need energy. Breathing also will increase myocardial oxygen consumption. So because of this, you got to intubate them. Alright? And the last one, post-cardiac arrest care protocol. Like I said, collapse, ROSC, not full GCS, you got to. We will talk about post-cardiac arrest care. Okay. I teach you ACLS. It's adult male, you use size 8, prepare one size smaller, 7.5. Adult female is we use 7.5, prepare one size smaller, 7. All these sizes means the internal diameter of the ET tube is size 7 is 7 mm. Size 8 is internal diameter of the ET tube is 8 mm. Clear? Okay, and where you should anchor. If let's say you use size 8 tube for adult male, go into 22 first. Check and slowly come out. Normally it's about 20 to 22. If you use size 7.5 for female, you go into 20 first, check. Normally it's 18 to 20. Just to say that you receive a patient from ICU to OT to A&T to ICU, the ET tube is level 24, 99.99% the ET tube is in the right side. Too deep in, right? You receive a patient from A&E to ICU with level of the tube is 18, in male, a lot of time cuff in the throat already. So this is a crude way to know. I teach you a bit more because like you got A&E people and all these, you got OT people. What happened to pediatric tube? Pediatric tube, okay, generally, age 1 to 10, this is extra, not in ACLS, but I think it's practical for you. Age 1 to 10, the tube you got to use, size of ED tube is age divided by 4 plus 4, or age divided by 4 plus 3.5, okay. Plus 3.5, these are because of the cuff tube. So age divided by 4 plus 4. For example, you have a patient 4-year-old. 4 divided by 4 is 1, plus 4 is 5. So size 5 you need to use. Always prepare one size bigger and one size smaller. If you have 8-year-old kid, that you want to use a cuff tube, 8 divided by 4 is 2. 2 plus 3.5 is 5.5. So you prepare one size bigger, one size smaller. Generally, pediatric, after 8 years old, you use a cuff tube because the natural anatomy of the trachea for after 8-year-old more well fit to the cuff tube. Alright? But in pediatric ICU, they have cuff tube even from size 3, 3.5. It's because in a pediatric ICU, because they ventilate for other reasons, for pediatric respiratory problem, this and that. So airway pressure very high. So you use non-cuff tube, they a lot of leak. So, but generally in pediatric OT, we don't use cuff tube unnecessarily. Why? Because the pediatric tube is so small. You cut extra like 0.5 mil also can impinge a lot on the tracheal mucosa, and the risk of post-tracheal stenosis is very high. You understand? So pediatric generally after 8 only I use cuff tube. But you have pediatric 6-7-year-old for tonsil, I also use cuff tube because tonsil will aspirate. You understand? So different. But generally after 8 we use cuff tube. Less than 8 we don't use cuff tube. And the size is age divided by 4 plus 4. For cuff tube is plus 3.5. And pediatric tube, where to anchor? You know, pediatric so small, sometimes you listen everywhere also you got airflow, correct or not? So pediatric tube for age 1 to 10, where to anchor is size of the tube you use, times 3 minus 1 to 2 marking. Again, size of the tube you use times 3 minus 1 to 2 marking. For example, you use size 5 tube. 5 times 3 is 15, correct? And pediatric marking, 1 marking is 0.5. So you can put about 14.15, 14.5 or 14. It's definitely not more than size of the tube times 3. You use size 5 tube by calculation. You normally don't take a 16 or 16.5 because it's too deep in. This is a crude way to tell you. This one will come up in the exam. But since you come for this, you're all clinical line vision people, so you should know this. Okay, Newborn, term baby, 3.5. Prem baby, 2.5. These are some extra things. Okay. Complication of intubation, of course, intubation is not easy. So you can become dentist. Extracted people's teeth, injury to the soft tissue. If let's say this is a live patient, a lot of times in OD you notice that when you zoom in, the BP can shoot up to 200. So these are a bit disastrous. And of course, arrhythmia can happen. The patient can have cardiac. That's why every time during intubation for live patients, always put the audio on. Because when you are intubated, the monitor is behind you. So you put the audio on, at least if the patient go by them, also I can see, I can sense. If the patient suddenly breathing, also I can sense. Things like this. Alright, how to confirm the ET tube placement? Once you intubate, then of course you can do a 5-point auscultation. You can see a vapor in the ET tube. But most importantly, you have to put the patient on end-tidal CO2 monitoring. And end-tidal CO2 is important. You have done the study on the resuscitation collapse patient. If you persistently having end-tidal CO2 or less than 10, the chances of the ROSC is near 0. Because end-tidal CO2, important thing is the index of cardiac output. Why? Because you only got perfusion, then the CO2 can be sent to the pulmonary capillary to be exchanged at the alveolar level to be sensed by end-tidal CO2, right? So if you're in your BP, in OT you notice the BP crash, end-tidal CO2 show low. The end-tidal CO2 that night show BP night. It's an index of cardiac output. Alright, this one we don't talk about it because we have talked about the airway management already. Alright, clear? So that's all about airway management. I hope you learn some principle about airway management during resuscitation. Clear? Alright, short break of 5 minutes. Then we can talk about drugs. Ask the first question. I'm sure the first drug that you all know during resuscitation is definitely adrenaline, right or not? Okay, from you are from which one?
6A.
6A, 6A also a lot of cholesterol. So I look code blue, 6A. Alright, is there a limit for adrenaline use during resuscitation? I mean, you come across your doctor, your A&E doctor, datang. So far, how many MPO of adrenaline have they used? You come across in your memory. No right or wrong. It's just that your experience, when people code blue come and do your resuscitation, berapa adrenaline people guna? 3 milligrams sahaja.
No.
3 milligram.
More than that.
I don't hear you.
More than 2 mg.
More, yeah. Don't give this answer. More than 3 can be 100, my dear.
In my experience.
Maximum that you have come across. How many MPO adrenaline they use during resuscitation? 9. How about you? 5. Never use. Wow, very lucky. Never work enough. Till 5. You? 4 to 5. 4. Like 9 like this. 10. Like 11. Never use. Put more in the end. 10. Never use. Wait, all these method, all the never use, I must send to A&E, let them experience resuscitation. 13, 14. 6. 10. Almost 20. That's the answer I want to hear. 20. You how many short? 9. Okay, do you remember just how I asked you? Is there a limit for adrenaline use? I tell honestly, it's no limit. But, you know, I worked 34 years. I remember one case, I was in UH as a trainee, and the collapse victim, very sadly, was my colleague. She is actually doing medical MRCP, is a medical colleague, very good doctor, but she has an SLE. And one day, she developed pulmonary hemorrhage, non-stop bleeding and collapsed. And at time, I remember we used 157 adrenaline from whole Klang Valley because resuscitated, reverted, but BP low, so run need adrenaline. It's just because my consultant cannot let go. He's such a good doctor, all right? But eventually she died. So, were you right to use that much of adrenaline? Even though I tell adrenaline got no limit, okay? But come to one case scenario. If let's say you've got a patient collapse and your first recognized rhythm is asystole, in the ACLS textbook, they mention that as long as the whole team are well AIS trained and you do everything correctly and the first recognized rhythm is asystole, you can call it off after 20 to 25 minutes. And you know resuscitation for adrenaline is 1 milligram every 3 to 5 minutes, right? And within the 25 minutes, the most you use 6. Alright, so that is a standard so-called. But I'm not saying that you must fix at 6. Because who knows that your patient from asystole go to VF and blah 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 this and that, right? So in fact there's no limit for adrenaline, but you need to know when to stop your resuscitation. Correct. So remember I told you already, if you have a case of asystole and the whole team are done correctly, you can call it off after 20 to 25 minutes. Now I changed my case scenario. Now, my dear, you have a patient, you got a patient of a 30-year-old, 70-year-old first, 70-year-old lady, come in with ventricular fibrillation, VF. How long you want to do your resuscitation until you call it off? You know VF, you every 2 minutes you got to shock once. So my question is, this 70-year-old lady collapsed with VF and continuously to VF, how long after that you can call it off? Just how I told you, asystole is 20-25 minutes, ma'am. How about this case? Until patient dies, you die very. How about you? Huh? 2 hours? Should I smell barbecue smell? Hey, you 2 hours, you nak shock berapa kali? You tell me. The answer is until patient died. So great. I said, should I smell barbecue smell? It is practical case, you got to know, because someone sometimes said, you are the team leader, you got to make a decision, right? What is your answer? You still want until patient die? 30 minutes. How about you? 30 to 1 hour. A 70-year-old lady, how about 30-year-old lady? You say 70-year-old VF, you put 30 minutes to 1 hour. 30-year-old lady? More than 1 hour. Die, I'm 60 years old. And I know to collect in front of you. You know I have resuscitated a 4 hours VF. So you want to until rhythm turn to asystole? Sure? Half hour to 1 hour. Half hour to 1 hour. 30 minutes to 1 hour. Yo, Understand my question? If this patient collapses with ventricular fibrillation, how long you want to resuscitate until you call it off, bring a death certificate and sign? Huh?
Lead to success, the result.
Okay. I tell you, asystole and VF are different. How the patient die or how the heart die, the heart is beating very well like this, okay? There is no problem. Then suddenly when the heart goes fibrillating, like this, clinically patient already dead because this type of fibrillation cannot generate cardiac output, right? So, but this type of fibrillation require oxygen and nutrient from the blood. So eventually, if let's say you do CPR, while your CPR very good, then you continue to send them 10% of oxygen and nutrient. But slowly the cause VF will become 5 VF, right? And very, very slowly asystole. So if you are dealing with VF patient and you continuously still be VF, two things. One thing is you can tell yourself my CPR very good, I continue feeding the VF, right? But another thing you also have to admit that even though my CPR is good, I'm not so good because I haven't found something to terminate the VF. Correct? So, but eventually this VF can be actually asystole. So if you are dealing with the case of VF, they are right, but they have to put it is you really cannot stop. A lot of time we cannot stop because when there is still VF, there is still some chance. Rarely you can stop. So I always tell people, you do until you collapse or you successfully collapse the patient. The principle is like this. But I want to share a case to you. With you, I actually have terminated a VF before. This patient is also very sad. But the patient pre-morbid is not good. Ejection fraction of 25%. Heart very good, very bad. And very sad he's quite young, about 50 something year old. Then EF of 25%. Then he got renal cell carcinoma. Have to come in for refractomy, and he's somebody, is my staff, my matron's brother-in-law. So, of course, this type of patient, you get ICU bed ready. But lucky or not lucky, I won't say. The operation is very successful. And operation is only 2 hours for refractomy. The blood loss is 200. So good, So, in GH ICU bed very, very tight. In the list, we sometimes got 5 patients waiting for ICU bed. So, the next one is a younger patient, heart good, but also with major surgery, definitely require ICU bed. So, with that, we got no choice to think that if he's so good, he can go back to the work. But I keep 3 hours in the recovery room. So, he's up finished by 2 o'clock. 200 ml of blood loss, very, very stable. Even with EF 25%, we keep 3 hours. So 5 o'clock, call the ward and send him. 5:30, he reached the ward. 15 minutes later, he BF. I tell you, I feel so guilty, Sudah balik rumah, I rush back, bring 3 consultants, bring 3 specialists, bring 8 MO, bring 2 defib machines from ICU, we do resuscitation in the ward. 4 hours. Shot 44 times. Refuse to go off the VF. We are successful maintain the VF, but cannot go off. So I did cardiologist come, his own personal cardiologist from GH, and he said, look, there's no chance he can come back. The minute we stop, okay? Then that is the only case we already maximize our resuscitation. I call it off. But most of the time, the VF won't treat you so well. That case is because, 3 specialists, 1 consultant, 8 MO, no many how many housemen, 2 defib machine, everybody, we just cannot let go because we feel so guilty. Alright, but this is an exceptional case. Most of the VF, you don't treat them well, they also don't treat you well. They slowly will go on. So you're dealing with a case of VF, be careful. Medical, legally, unless you got cardiology, you come and certify things like this, we normally cannot call it off. Clear? Okay, come back to our adrenaline. Adrenaline, number 1, it becomes a so-called drug of choice for resuscitation. Partly because we don't have other alternatives, I tell you honestly. And adrenaline is 1 milligram in 1 ml in an ampule, right or not? Have you heard of high-dose adrenaline? Have you heard of high-dose adrenaline? High dose adrenaline was a standard protocol last time, more than 15 years ago, when I was at MO. I like to mention this because a lot of people still now like wanted to use that. High dose adrenaline means that 0.1 to 0.2 milligram per kilo. So if your patient is 50 kilo, 0.1 is 5 milligram bolus, 0.2 is 10 milligram bolus. So 15 years ago when I was at MO, we happily use this type of high dose adrenaline because the outcome is very good. They don't die during your on call. They died 801, orang lain tulis their certificate. No? It's real, but there's a reason why ILCO need to be there. ILCO, because everybody do that, and I also like to do that, bang 10 milligram, ROSC, tulis cepat-cepat lari, you know, then show the patient will die later. You know, so the ILCO have done study on the animals, so induced cardiac arrest, then one group use the standard dose, one group use a high dose. They found out that immediate outcome is very good for high dose adrenaline. Immediate outcome, immediate ROSC. But they continue their observation until after 24 hours. The high dose, most of them died. So with that study before 2010 guideline, they actually come up with consensus understanding that high dose adrenaline causes direct myocardial damage. So high dose adrenaline not good. So now we use standard dose of adrenaline. And standard dose of adrenaline is 1 milligram every 3 to 5 minutes. Alright? So it's standard dose adrenaline. Right? Adrenaline, remember the adrenaline 1 milligram bolus you can only give to those with no cardiac output. Means that you use VF, pulses, PD, PEA or asystole. Never give adrenaline 1 milligram bolus to even unstable BP case because you will induce cardiac VF things like this because it's very arrhythmic. And adrenaline has a very high sympathetic response. You shoot out BP, very high mild oxygen consumption, also can cause increased cerebral perfusion, things like this. But adrenaline, I tell you, is a drug of choice in all the resuscitations, even though it's infusion. Adrenaline infusion is a standard first line for those bradyarrhythmia, high degree heart block means that second degree type 2 or third degree, because this type of second degree type 2 or third degree heart block is very high degree heart block. So you normally don't respond to atropine, even though you still order, okay? And most of the time you require the transvenous pacing from cardiologists, right? So while awaiting for cardiologists to come, while awaiting for cath lab to be ready, you put patient on infusion adrenaline. How to dilute, you need to know. 3 milligram in 50. Nowadays, all the inotrope except noradrenaline, we dilute with normal saline. Okay, because too much glucose is not good. Alright? So, adrenaline infusion is important for high degree heart block while awaiting for pacing. Alright. So these are the drugs that we talked about, A or D, adrenaline. And okay, before we talk about this drug, there's a small part that we have to mention is routes of administration of the drug. During resuscitation, how you give drug? Of course, number one is IV, intravenous. Number two is intraosseous. And number three is endotracheal route. But this endotracheal tube route of administration is slowly disappeared from algorithm because it's very unpredictable. Can you imagine in the ET tube, when you ET tube route of administration, you flush a drug there, a lot was stuck at the tube itself. And what is the rationale of ET tube route of administration is because the trachea is incomplete C-ring, alright, cartilage. Belakang is tracheal mucosa, and inside this tracheal mucosa got capillary. So your drug, when it's stuck there, it will slowly absorb through the trachea capillary and go into pulmonary circulation and slowly systemic circulation. So means that the dosage of the drug you need to use is actually very high, right? Even though they say 2.5 to 3 times of the drug, like means IV you use 1 milligram, this one you need to use 3 milligrams, you know. But people have done study about the adrenaline given IV and adrenaline given through the endotracheal tube. They found that at least 10 times, that only can be equivalent in the blood concentration. So that's why ET tube routes of administration is unpredictable and they remove from the algorithm. Alright? And IV, if your patient collapse and no line, I ask you, where is the line you want to set? Patient collapse, no line, you think about CPR. You know, IV line got 2. Central line and peripheral line. Which one you think is a better one? Central line. Where are the central line? Internal jugular, subclavian, femoral. These are the central line, right or not? Femoral out, you know why? Because during CPR, your intrathoracic pressure is high. Femoral very difficult to reach the heart, right? So you left only subclavian and internal jug. When I say during CPR, your patient, your colleague's hand is dong 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 on the chest. Do you think you can do subclavian and poke to your friend's hand, right? Do you think you can do internal jug? Internal jug, this positioning, you want to back. So central line during CPR is, I tell you, is nearly out. Is nearly out because you cannot position, right? Even though central line, good thing is, of course, very fast, reach the heart, but it's not practical during CPR. So means that peripheral line. But peripheral line, mana, normally you should set above, not below the diaphragm, okay? And whatever you can get, alright, you know. So intravenous is the standard. Last time is like 2010, 2015 guideline. They are talking about intraosseous and intravenous are as effective as each other. You know, intraosseous, where is it? Intraosseous line administration. Intraosseous was actually first described by pediatrician in 1930s. And that time intraosseous, mana dia said pediatric is lower tibia, lower femur, upper tibia, right? But can you imagine adult? Even the 80 kilo, 70 kilo adult, kaki begitu besar, how to get the intraosseous, right? So intraosseous route of administration of cardiac resusc drug during CPR is not lower femur, upper tibia. It's iliac crest. You know, iliac crest, you can feel the bone, right? Or sternum. But sternum provided kalau tengah buat CPR cannot. You know, you probably reverted already, then you only lie difficult, then you set sternum. So it's mainly iliac crest. That is for intraosseous. Last time used to say that intraosseous and intravenous are as effective as each other, but 2021 guideline they put it no. They have done enough study to find out that intravenous still better than intraosseous. Okay, so intravenous first, after that intraosseous, right? Why intraosseous is in the picture is because it's very vascular. You know, it's bone marrow, right? So very vascular. So you can give drug, you can take blood, you can actually run quick. That is intraosseous. Yeah. Okay. Adrenaline we mentioned already is bolus is only for no cardiac output algorithm. And the action we mentioned already. Dosage we actually mentioned already. Okay. Anaphylaxis we talk about here is because a lot of y'all deal with that. But in anaphylaxis or anaphylactic shock, you give adrenaline is we run 1 in 10,000 because the 1 milligram 1 ml is 1 in 1,000, right? So you take up 1 ml, dilute to 10 ml is 1 in 10,000. Then you slowly titrate until BP come up a bit, then you run infusion, alright? But for ALS resuscitation, for collapsed patient, bolus. For bradycardia, infusion, alright? Okay, standard dose I mentioned already. Okay. Amiodarone is the drug very easy to mention in the exam because why? Because whatever tachycardia you can use. Whether the tachycardia originate from above ventricle, we call supraventricular tachycardia, or the tachycardia arise from the ventricle, both also you can use. Alright? What is amiodarone? What is amiodarone? It's an anti-arrhythmic drug. Anti-arrhythmic drug, you got grade group 1, 2, 3, 4. Okay? And amiodarone has group 1, group 3, and group 4 effect. Okay? Only group 2 type. So it's actually very good. And it's the indication of amiodarone. Listen carefully, no need to write. Amiodarone, the indication for resuscitation 3. The first indication is no cardiac output state, okay? Which type of condition you use amiodarone is when there is refractory VF and refractory pulses VT, okay? What do you mean by refractory? Clever boy. refractory VF and refractory pulses VT is a VF or pulses VT resistant to 3 shock. Okay, so you use amiodarone IV 300 milligram bolus because it's no cardiac output state, so you will not worry about, because amiodarone causes bradycardia and hypotension. But already no cardiac output, so you shoot in 300 milligram. Amiodarone come in which type of packing? Okay, the valve is 3 ml, each ml is 50 milligrams. So you want 300, you take 2 valves, correct? So amiodarone first indication is for no cardiac output state, refractory VF and refractory pulses VT. Second indication for amiodarone is unstable tachyarrhythmia. In fact, unstable tachyarrhythmia, what you do is you do cardioversion right now. So failed 3 times cardioversion, so unstable tachyarrhythmia, failed 3 times cardioversion, you also give amiodarone. You also use 300, but even unstable got BP, right? So you cannot give bolus, right? So you give 10 to 20 minutes. Alright? Unstable tachyarrhythmia, failed 3 times cardioversion, then you give 300, run 10 over 20 minutes. This protocol, this regime, we follow ERC because very easy to remember all 300. One is bolus, one is 10 to 20 minutes. Alright? And the third indication of amiodarone in resuscitation is stable tachyarrhythmia. Stable tachyarrhythmia is stable, right? But you need to revert. So you use 300 milligram, run 20 to 60 minutes. Clear or not? Okay. Test you 1G. What is tachycardia? Berapa cepat is tachycardia? Very good, more than 100. But will you treat the patient in 100 or 120? You know, right? So, how fast is the fast that you must treat? More than what?
150.
Huh? Huh?
150.
150. Who say 150? Hands up. But can you explain to me why 150 you must treat? It must be a reason. Nowadays, evidence based medicine, right? Tak boleh because of my personal opinion, level 5 evidence medicine. Why 150 you must treat? It's nothing to do with cardiac output. No, he actually mentioned about cardiac output. You know what is the formula of cardiac output? Cardiac output equals to stroke volume times heart rate. Okay, alright. And stroke volume can reach a maximum because stroke volume depends on myocardium fiber. Satu heart punya fiber is fixed, right? So it can stretch maximum. So at one point, cardiac output directly proportionate to heart rate. Hey, the more the better, correct? You talk about cardiac output is wrong. The explanation of cardiac output for the heart rate high you got to treat is wrong. Because when you look at this formula, cardiac output will proportionate to heart rate. So heart rate lagi tinggi, lagi bagus, betul tak? So tak betul. Your cardiac output is wrong. So why heart rate so fast you must treat? It's because when the heart pump, we call systolic, right? When the heart relax, we call diastolic, right? So when the heart pumps systolic, you will pump the blood to the brain, to everywhere, correct or not? So, but when you relax, what will happen to this heart? It receives the coronary perfusion to perfuse itself, make itself actually viable, right? So they need diastolic phase. But when the heart rate more than 150, the diastolic phase is very minimal. So the jantung tak dapat oxygen, the jantung tak dapat perfusion itself, jantung akan mati. Correct or not? So heart rate more than 150, you must treat because the diastolic phase is too short. Then the heart cannot sustain its viability. Clear? Okay, now ask you another thing. What is bradycardia? Heart rate less than 60. Oh, you don't treat the patient at 148, you know, because a lot of people on beta blocker, 144, 146, you don't treat, right? So how low you must treat? Just how high you will treat is 150 low. How low you must treat? Cannot, must inform doctor. Must give atropine. Less than 40. Now your cardiac output come in. Okay, now you can use cardiac output to explain why 40. Because you see, we already said that cardiac output is proportional to heart rate. So any heart with a heart rate less than 40, sure cardiac output drop. So you must treat. Understand? These are again the principle. Alright, So now we talk about amiodarone. We already say that 3 indications used for cardiac arrest situation is refractory VF and refractory pulses VT. You use 300 milligram bolus. Second indication, unstable tachyarrhythmia, failed 3 times cardioversion. Give a dose of amiodarone before your 4th cardioversion is 300 milligram 10 to 20 minutes. Alright? And the third indication is stable tachyarrhythmia, but heart rate more than 150, you must treat, right? So use amiodarone 20 to 60 minutes. Clear? Okay. Amiodarone structure itself is thyroxine-like structure. Dia macam thyroxine. So amiodarone, be careful. If let's say your patient SVT ke fast AF or whatever is due to thyroid storm, thyrotoxicosis, you think 10 times. A lot of cardiologists tell you don't treat amiodarone because it's thyroxine-like. So you actually can make your thyroid function test even more haywire. Alright, so what to treat? It depends on. If let's say it's tachyarrhythmia because of ventricular tachycardia, then you can treat with it, okay. If let's say tachyarrhythmia due to the supraventricular, then you probably treat adenosine. Forget about amiodarone. Clear? Okay. And what is the main side effect? Of course, this I mentioned already. The side effect, it can cause hypotension bradycardia. Important. Alright, I remember I told you this morning how to fail my mega code. If I give you a heart rate of 30, you go and give amiodarone, bye-bye. Correct or not? Alright. Then, amiodarone, you actually can, it has a very, very long half-life. And it can be actually given oral, okay? So those that chronic use, they actually can get pulmonary fibrosis, can get the micro deposition on the cornea, things like this. But acute is hypotension bradycardia. Right? Okay, now we finish 2 drugs. Okay, so far? That's why you must listen, don't write, everything is in the book. Okay, the third drug is adenosine. Adenosine, what you need to remember to know is adenosine used for what? SVT, supraventricular tachycardia. Yeah? And adenosine, what is the standard regime protocol now in 2021 guideline? 6, 12, 18. AHA is 6, 12, 12, still 6, 12, 12. So I don't know what happened to the later one. 6, 12, 18 is ERC. And NCOT, most of the things we follow ERC. So 6, 12, 18, alright? And adenosine, remember, the half-life is very short. How short? 5 to 6 seconds. So why? Because if you give very, very slow, it's actually metabolized by non-specific esterase in the blood. So you give slow, you sudah jadi not effective metabolite already. So you have to give fast. But you have to remember, adenosine when zoom in, you must have a cardiac monitor because it causes transient asystole. Very scary lah. Zoom, patient macam asystole. You hope it come back again. Alright. And adenosine, what is the most important side effect? This one I gone through. Okay, it's very scary. You know, we are called to a surgical ward because the patient got SVT. No? So we happily go there, give adenosine, so. After that, reverted my patient. Patient got, because it induced severe bronchospasm. At last, we got to intubate the patient because of bronchospasm. So these are important. 1 is you have to give very fast. 2 is contraindicated with those with very severe asthma. Alright, so that's the adenosine you need to know. Okay. Okay, very chatty. No COVID,
No COVID.
Okay, the next drug to use is atropine. Okay. Atropine, in 2015 onwards, also people don't use for asystole anymore because study shows that it's not effective. So asystole now sekarang kita guna adrenaline sahaja. Atropine now is 1 milligram in 1 ml. Dulu got 0.6 milligram, very confusing. So we use 1 milligram. And atropine bolus we don't use anymore. We use 0.5 milligram. When I say 1 milligram, we don't use 0.5 milligram every 3 to 5 minutes for those with bradycardia. Alright? And atropine is anticholinergic, so it can cause dry eye, things like this. And it actually can cause central anticholinergic syndrome. Patient will flushing, tachycardia. But that is if you use atropine for some toxicity. Alright? So atropine very simple. Now it's only used for bradycardia. Alright? And symptomatic bradycardia. And the dosage is still 0.5 milligram every 3 to 5 minutes up to 3 milligrams. Alright, we follow A to Z. So now it's dopamine, dobutamine. Dopamine, dobutamine, noradrenaline, adrenalines are all we call adrenergic receptor. Okay, these are all inotropic agents. They can increase the contractility and increase the BP. Generally, in the research, to say honestly, dopamine nowadays not much effect. You know, in fact, in my ICU GH, we don't use dopamine. You know, because it's not effective. But in the resuscitation, because most of the patient has only peripheral light, you know, so you want to prepare dopamine also, you will okay, alright. But you just need to remember, dopamine, dobutamine, noradrenaline, they are all adrenergic receptor and agonists. So they work through alpha 1, alpha 2, beta 1, beta 2, correct or not? And dopamine also got extra dopaminergic receptor, alright? So it so-called increase the perfusion, increase the heart rate, all this, and they increase the perfusion in the kidney for dopamine. And the dosage, of course, how to prepare? Standard we tell you is just to, you know, 1 ampule is actually 200, right? So you take it out, dilute with normal saline, titrate accordingly. We normally will start at 10, then every 5 minutes you check your BP, alright? And dobutamine is actually predominantly beta 1 effect. Beta 1 effect is increased pumping effect. So if you think your patient collapse because of heart failure, heart pump failure, right? So you can put patient in dobutamine infusion, alright? But dobutamine, it also got beta 2 effect, like it causes smooth muscle dilatation. So sometimes that patient collapse, they don't come with only one problem, right? They can be septic, cardiogenic, that type of thing. So if you just start dobutamine, sometimes the BP can crash. You know, it's because it works through also beta 2, alright? But purely heart problem, you can start with dobutamine. You don't know what problem, you can start with dopamine. You also can start with adrenaline nowadays. But adrenaline, you must quickly get the central line in, alright? Then, what happened to noradrenaline? What happened to noradrenaline? Noradrenaline is predominantly alpha 1 effect. Alpha 1 is peripheral vasoconstriction effect. So, noradrenaline indicated for septic shock patient, because septic shock, the pathophysiology is vasodilatation, right? So you must use something to vasoconstrict effect. So you think your patient collapsed because of septic shock, then you can use noradrenaline as a first line. Alright, so these are how you actually adjust in your resuscitation. Now we talk about lignocaine. Lignocaine used for what? Lignocaine used for what? Lignocaine. Which type of tachyarrhythmia? Which type of tachyarrhythmia for lignocaine? Ayong? Remember just now I told you, if the tachyarrhythmia comes from supraventricular tachycardia, you use adenosine. If let's say the supraventricular tachycardia and ventricular tachycardia, you can use amiodarone. But if this is only from ventricular tachycardia, you use lignocaine. Remember this, this is another exam question. SVT, adenosine. VT, lignocaine. SVT and VT, you can use amiodarone. Okay? So lignocaine is 1 to 1.5 milligram per kilo. That is AHA criteria. But remember your amiodarone we use for refractory VF and refractory pulses VT, right? So you also can alternative is lignocaine. If you don't have an amiodarone for refractory VF and refractory pulses VT, you can use lignocaine. Remember amiodarone we use 300, right? and after fish shock you use another 150, right? But for lidocaine, you use 100. Then fish shock, you use 50. That is an ERC guideline. AHA, lidocaine, they tell you 1 to 1.5 milligram, very confusing. So we still follow ERC. So you want to use a refractory VF and refractory pulses PT. If you don't have amiodarone, you can use lidocaine. And the dose is 100. Okay. After fish shock, you can repeat another 50. Then no more. Alright, so that's lidocaine. Alright, and magnesium. Magnesium you use for what? Very good. What is the dose? Later you go and see. Mention tomorrow, bring the magnesium for them to see. Because you see, you have to see what is inside is in millimole. No, very confusing. No, I didn't mention her. Okay, vasopressin. Vasopressin is another cardiac drug. Vasopressin come back to the algorithm for 2021 guideline. Where should you use? What is the indication for vasopressin? Is to replace first or second dose of adrenaline wherever you can use adrenaline. Okay, how much you use is 40 international units. One is actually 20, so you have to use 2. Why is it can replace the adrenaline whenever you use adrenaline, first or second dose. And we don't repeat vasopressin because vasopressin is long acting. How long is at least 10 minutes. So, and it's not so easily available. So we still use your adrenaline as a standard drug for the resuscitation. Vasopressin you can use also. Okay? And as vasopressin in ICU, they use for septic shock patient because vasopressin has a very strong, potent peripheral vasoconstriction effect. So they can use for ICU septic shock patient as vasopressin. Alright, verapamil. What is verapamil? What is verapamil? Good. It's a calcium channel blocker. Calcium channel. Oh, we have invented before we talk about verapamil, we talk about calcium first. It's a calcium cardiac resuscitation drug. Yes or no? Who has used calcium during their resuscitation? Come across people use calcium. Hands up. Huh? Nobody. I thought a lot of people A&E like to use calcium. No, I mean the cardiac arrest during CPR. Will you all use calcium? No. Very good girl and good boy. Okay, calcium per se is not first line cardiac resuscitation drug. But calcium has its own good point. You know what is the effect of calcium? Do you know? Calcium itself is a positive inotropic agent. What do you mean by positive inotropic? It actually causes increased contractility of the heart. So it's very good. It increases contractility of the heart. It's a positive inotropic agent. Second thing is, calcium is a very good membrane stabilizer, especially for myocardium. So it will stabilize the membrane and reject or prevent so-called low ventricular fibrillation, that type of thing. So it's a very good membrane stabilizer. And third thing, calcium itself is a very good cofactor to activate the sleeping clotting factor in normal hemostasis. That's why you see in OT, like patient got massive bleeding or all this, anesthetists like to give a dose of calcium. Because so calcium got 3 main effects. One is positive contractility. 2 is membrane stabilizer, especially stabilize the myocardium. And 3 is hemostasis. It is a cofactor to activate sleeping clotting factor. So to induce the patient's own hemostasis. And how many types of calcium do you have in hospital? Calcium chloride plus calcium gluconate for IV, that is 2. What are the difference between these 2? Is there a difference? We have calcium chloride 10 ml, we have calcium gluconate 10 ml. Even though I say they are so good, but it's not a first line cardiac resuscitation drug. You don't simply just take calcium and do, alright? There are 2 types of calcium, chloride and gluconate. in terms of what is the difference is because calcium chloride has 3 times more calcium ion in the calcium chloride. It's 6.8 millimole of calcium ion. And calcium gluconate has 2.2 millimole. So calcium chloride is very sticky. Alright? So calcium chloride you must give through central line. Because you give through peripheral line, extravasated can cause disaster, can cause necrosis. Alright, so a lot of private hospitals got no calcium chloride. Why? Because you don't simply put central line, right? Calcium gluconate you can give through peripheral line. What is the commonest use for calcium gluconate in hospital? Medical pun paling tahu. Hyperkalemia. You say, well, I want to give lactic cocktail, correct or not? Okay, do you think calcium gluconate is really part of lactic cocktail? But everybody give, right? It's a combination of insulin, dextrose 50 and calcium gluconate, right? No? But to say honestly, I just want to explain to you, a lot of people just give like this, but they don't understand why they give calcium gluconate. Right? Calcium gluconate per se is really not a drug so-called as a lactic cocktail. What do you mean by lactic cocktail? It's because potassium very high. So whatever drug this so-called drug or lactic cocktail, it has the effect of remove the potassium from the blood to the cell, correct or not? So in the blood don't have hyper K, then you don't have arrhythmia, VFs and that, right? Do you think calcium gluconate has this type of effect? Does it remove the potassium from the blood to the cell? No. We give calcium gluconate is because, number one, it acts very fast, within few minutes, alright? So, and you know every drug you give, sure you need to wait for the onset time, right? Again, I come back my instant me story lah. When you say instant me, Maggie, you cook Maggie take time or not? How long? 3 minutes. Now very keras 3 minutes. So all the drug got the onset time. Do you know the drug that really has the effect of remove potassium from the blood to the cell is insulin. Alright? But insulin take how long to work? 20 to 30 minutes, no, not so fast one. Okay? And you give dextrose 50 because you give insulin, right? So insulin is the drug mainly to remove the potassium from the blood to the cell. But while awaiting for insulin to work, you need something to stabilize your membrane. Don't go VF, correct or not? And the calcium work very fast, within few minutes. And calcium go off after 25 minutes. So when the calcium go off, your insulin working. Correct. And you see, whichever case, you never know which patient, which potassium will cause VF because I've seen 5.5 potassium cause VF because this patient ejection fraction 20%. I've seen people walking around with 8, potassium because his heart is normal. His EF is 70%. So therefore, every case of so-called hyper K, you give one shot because you never know until patient go VF died. Correct? So now you understand. So that calcium gluconate as a lactic cocktail is because it works very fast. So it has a good membrane stabilizing effect. Clear? So calcium is not a first-line cardiac resusc drug. To say honestly, you want to give calcium because you know your patient got pump failure, then you should give calcium chloride. But calcium chloride, you need central line. Alright, so come to our verapamil. Just now we talk about calcium is a good contractility, positive inotropic agent, right? And the verapamil is calcium channel blocker. Means that the main problem about this verapamil, it can drop the BP, right or not? And verapamil used for what? It actually is used, it is an alternative for SVT. When you don't have adenosine or your patient because of asthmatic badly, this and that is contraindicated to use adenosine, you can use verapamil. How to use? All these young people don't know how to use because it's an old drug. Everybody adenosine. So verapamil is 2.5 milligram in one ampule. So normally we string out this 2.5 milligram dilute to 10 ml. So you titrate. That's how we actually give verapamil. Okay? But it is still a good drug for the heart. Alright. Okay. This is another drug. It's very misleading. Everybody like to. Have you come across your doctor use sodium bicarb during resuscitation? Yes, right? Okay. I'm not saying that it's definitely wrong, but this is not first-line cardiac resusc drug. Unless you know your patient is in ICU and you know this patient is very acidotic, probably pH less than 7.1. So acidotic, the biocardium won't be sensitive to all the catecholamine, all the vasoconstrictor, then you can give. If not, during resuscitation, sodium bicarb is only indicated in those prolonged resuscitation. Means that after 15 minutes of CPR resuscitation still got no ROSC, then you expect there will be some form of lactic acidosis already, right? Then you can give bicarb. Or you have a definite ABG to show that pH is less than 7.1, because pH less than 7.1 is normally non-salvageable, that type of things. So you can use the sodium bicarb. You don't use it as a first line. Alright? Okay. Calcium talk already? The next thing is a steroid. Steroid it become a very hot topic in actually before 2015 guideline. It's because in 2010 guideline, people started to understand that there is a syndrome called post-cardiac arrest syndrome. Do you know what syndrome is this? Post-cardiac arrest syndrome. And this syndrome is 100% developed in the victim with the cardiac arrest, CPR, and got ROSC. So in a patient, the victim go through cardiac arrest, CPR, and ROSC, 100% of them develop this syndrome. Later we'll talk about it in the post-cardiac arrest care, alright? So at last they found out that this post-cardiac arrest syndrome is a kind of inflammatory response syndrome. So when this is something to do with inflammation, people think that steroid work, correct or not? So therefore from 2010 to 2015, there are so many studies done for steroid. And they divide the study sample into two groups. One is IHCA, in-hospital cardiac arrest. One is OHCA, out-of-hospital cardiac arrest. Alright? And the conclusion is very sad. For out-of-hospital cardiac arrest, they just two words, not good. Okay? For in-hospital cardiac arrest, the word is one word, inconclusive. Kesian, semua tak work. Because they actually done study about like out-of-hospital cardiac arrest, because they are 911, all the paramedics very good. So they actually give either is metaprednisolone, hydrocodone, or dexa. They have done study and they found out it's actually not good. But does it mean that steroid really not good? I already told you that in-hospital cardiac arrest inconclusive, out-of-hospital cardiac arrest not good. But there's something called VSE. This one also come out in the VSE, capital letter V, then capital letter S, capital letter E, VSE protocol. VSE protocol stands for protocol including using vasopressin, using steroid and epinephrine. Alright? And this protocol has a huge study on human subject. It's done in the tertiary cardiac center at Greek, G-R-E-E-K, not our G-R-I-K, alright? And the sample more than 10,000 collapse victims, it's a referred case to this tertiary cardiac center. And the outcome is very, very good. I was lucky because I went to Dallas for the 2015 guideline consensus meeting. And there are a lot of debate about this because it's so good study, so good outcome, and the outcome including go back to work after 6 months. And is statistically significant, P less than 0.001. Okay. But why 2015 guideline? This VSE protocol is just like, the treatment recommendation is VSE protocol may be considered. It's not strongly recommended, even though it's so good. It's because there are 3 big studies on this protocol, and all these 3 studies done by the same investigator at the same center. Then you cannot avoid the bias. So they hope 2020 guideline can come out and do more, but after that COVID, so nothing do. So 2021, nobody say anything about it. But this VSE protocol is interesting because people go back to work after 6 months is significant. Alright, and how is the protocol? They actually, the steroid they use is metaprednisolone 14 mg. So they use the first cycle is adrenaline 1 milligram, vasopressin 20 units, plus beta-prednisolone. Then after that, they use only adrenaline. And if any time the patient got ROSC, they give IV hydrocot 100 milligram for next 7 days. Okay, and that's how they do. So that remember, not all the steroids are bad. There is something called VSP that it could be better. All right. I end this drug in this new guideline, 2021 guideline, is because aminophylline. What is your understanding about it? It's used for what? Aminophylline. Used for asthma, correct or not? Used for asthma, right? By 2021 guideline, your call worldwide, they actually come up a recommendation. Aminophylline IV can use for certain type of bradyarrhythmia, especially those bradyarrhythmia due to post-inferior MI. Okay, post-inferior MI, or the bradycardia post-cardiac transplant, or bradycardia due to neurogenic shock, spinal shock, those paraplegia, then during the recovery phase they have it. All because, you see, bradyarrhythmia normally use atropine, right? So these are the certain conditions that atropine won't work. For example, post-inferior MI. Inferior MI, they include it is mainly supplied by RCA. Now this RCA is right coronary artery. And this right coronary artery also supply SA node right now. So, and when the SA node not viable, because of the blockage of RCA, this and that, post-MI, so your atropine won't work. It won't stimulate your SA node to work again and all this. So therefore, they found out that aminophylline work. So you just need to know aminophylline is indicated for certain type of bradyarrhythmia. There are a lot of differences in the recommendation of the dosage. I think ERC use 100 milligram IV. AHA use 250 milligram. So I even asked the Singapore Resuscitation Council. They said because we never use it, so we don't know. Okay, I checked with Dr. Barakat before, about this aminophylline. And actually, amazing. He told me, yes, last time we used to give Neolin SR 2 weeks for people with post-inferior MI because of his bradycardia. So I think there must be definitely some positive result, so that's why they use aminophylline. Okay, so the new thing you just need to know.